Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in our surgery lecture number 20, that is the endocrine neoplasms of pancreas. In this lecture, we will see the insulinoma, the gastrinoma, that is the Zollinger-Ellison syndrome and WDHA syndrome. Okay, let's start. Endocrine neoplasms of pancreas. Insulinoma. First is the insulinoma. Insulin producing adenoma of beta cells is the most common islet cell tumor. Due to excessive secretions of insulin from beta cells lesion, there will be attack of hypoglycaemia, confusion, stupor and loss of consciousness, promptly relieved by feeding or parenteral administration of glucose. This is classical whipple triad and very much characteristic of insulinoma. Now the pathology in insulinoma are 70% of insulinoma are solitary adenomas and 10% of insulinoma are the multiple adenoma, 10% of insulinoma is the metastasizing tumor and 10% insulinoma is a mixed group of diffuse hyperplasia of islets. These are usually encapsulated, firm, yellow and brown nodules. Microscopically composed of cords and nest of well differentiated beta cells. Dear student, you can see the image on your screen is the insulinoma, image of insulinoma, and next image on your screen showing the CT scan image of the insulinoma of pancreas, clearly seen by the arrow in this image. Next is also showing the insulinoma, image of the insulinoma. Now the clinical features: blood sugar falls rapidly to release of epinephrine caused by the hypoglycaemia, sweating, weakness, tachycardia, hunger and trembling. Produces cerebral symptoms, headache, mental confusion, visual disturbance and convulsions and coma. Bizarre neurologic and psychiatric disorders are not uncommon in this condition. Treatment: only permanent cure of this condition is excision of tumor. Diazoxide may be given to inhibit insulin release from beta cells. This drug inhibits insulin release directly, causes release of glucose from the liver and interferes with peripheral utilization of sugar. Streptozotocin, a broad spectrum antibiotic, is a powerful agent for control of the symptoms of insulinoma. Destroys islets but must be cautious about its toxic side effects. Simple excision is sufficient as these tumors are benign. Insulinoma tumor is benign. Next is the gastrinoma, that is the Zollinger-Ellison syndrome. In 1955, Dr. Zollinger and Dr. Ellison from Ohio State University first defined this disease. Delta cells, that is the D cells of islet of Langerhans, secrete somatostatin and gastrin. The latter hormone is also found in G cells of the gastric mucosa. Somatostatinomas are rare tumors. Gastrinomas are much more common. In this condition, peptic ulcer develop for high acidifications of the stomach due to stimulation by gastrin, which is being secreted by this tumor known as the gastrinoma. The pathology behind this Zollinger-Ellison syndrome, that is the 60% are malignant and 2/3 have already metastasized when detected. 40% are benign, 30% are adenomas and 10% hyperplasia of islets. These usually consist of adenomas of other endocrine glands such as pituitary, pancreatic islet, that is the beta cells, parathyroid and adrenal cortex. This is not a familiar disease. Dear students, you can watch the image on your screen, that is the Zollinger-Ellison syndrome. The tumor gastrinoma is situated in the head of the pancreas. This is the typical sign in the duodenum. There is a sign of gastrinoma. Dr. Zollinger and Dr. Ellison is seen in this image. Rare endocrine disorder disease. 3 interrelated pathologies are there: gastrinoma, gastrin secretions tumor, increased gastric acid and secretions and develop peptic ulcer. Here is another image, image A and B, clear cut seen genuine ulcers. Now the clinical features of the gastrinoma, that is the Zollinger-Ellison syndrome. 3rd and 4th decade of life show an ulcerogenic diastasis. 75% of ulcers occurs in the usual sites within the stomach or first and second parts of the duodenum. About 2 to 3 liters of fluid is found in 12 hours in the nocturnal secretions. A ratio of basal acid output to maximal output, that is the histamine and stimulant, is more than 60%, and this is the almost diagnostic of Zollinger-Ellison syndrome. Gastric hypersecretion is associated with distressing watery diarrhea in about 1/3 of cases. About 2 to 8 liters of liquid stool daily has been reported and may precede the onset of peptic ulceration. Now the treatment of gastronoma is high dose of H2 antagonist, that is the omeprazole, to control the ulcer. Omeprazole inhibits the gastric secretions. Surgical management. Gastronoma in the duodenal wall or in the pancreas should be shelled out. Solitary lesions in the tail can be treated by tail resection. Only in case of multiple lesions in the head of pancreas, a whipple resection, pancreaticoduodenostomy, is necessary. If no lesion or metastatic is detected, then truncal vagotomy and pyloroplasty should be performed. Next point in this lecture is WDHA syndrome. WDHA means watery diarrhea, hypocalcemia and gastric acidity or hypochlorhydria. That is the WDHA syndrome. First letters of each symptoms. Diarrhea is usually profuse 4 to 2 liters per day, that is the pancreatic cholera also be called. Causes behind this WDHA syndrome are secretions of phosphoactive intestinal peptide, pancreatic polypeptide, gastrointestinal inhibitor peptide and secretin. First 3 hormones are secreted by PP cells of the islets and will cause such a syndrome. 40% behind the tumors, 40% malignant tumors with metastasis and only 20% hyperplasia of these cells of the islets. Treatment is resection of these tumors. Here is another image, that is the Hypoma, Werner's-Morrison syndrome, WDHA, watery diarrhea, hypokalemia, achlorhydria and pancreatic cholera. All these are the symptoms of Hypoma, that is the Werner-Morrison syndrome, means WDHA. Dear students, here is the end of our surgery lecture number 20, that is the endocrine neoplasms of pancreas. Thank you.